We're very fortunate to have a group of experts to tell us just how they do that for which they are really perhaps best known, or at least one of the things for which they are quite well known.
With those words, William H. Moritz of the Medical College of Georgia succinctly introduces the theme for this edition of Audio Digest Surgery, Volume 18, Number 10, How I Do It. Recorded originally at the American College of Surgeons sectional meeting in New Orleans, the 6 surgeons and their areas of special interest that you'll be hearing include George V. Brindley, Jr., hiatus hernia, John L. Sawyers, esophageal perforation and mediastinitis, J. Linwood Harrington, Jr., the short bowel syndrome and post-vagotomy diarrhea, James R. Jude, cardiac arrest, Hermes C. Grillo, tracheal stenosis, and W. Dudley Johnson, coronary artery disease. And now to begin, here again our program moderator, William H. Moritz.
The first of the How I Do It topics is by Dr. Walter Brindley of Temple, Texas, on how I treat hiatus hernia. Dr. Brindley.
We treat hiatal hernias in several ways depending upon the conditions that are present and the condition of the patient at the time surgery is elected. If the hiatal hernia is the only abnormality that is thought to be present, and we can be reasonably certain that there are no intra-abdominal diseases that need to be searched for or corrected, and if there is no thoracic contraindication to the use of the thoracic approach, such as a pleural empyema that might have been present previously on the left, and especially if the patient should have intrathoracic disease that needs to have examination and correction, we prefer the left thoracic approach. Most of these patients are obese, and technically the procedure is much easier when performed through the chest. A long time ago, we removed a long segment of the 8th rib for this approach. We presently use an intercostal incision, ordinarily in the 7th intercostal interspace. We carefully examine the intrathoracic contents to be sure there is no coexisting disease. The inferior pulmonary ligament is divided on the left, the lower lobe of the left lung retracted superiorly, and the esophagus carefully examined. We've had 8 patients that have had coexisting carcinomas of the esophagus with their esophageal hiatal hernia, and the diagnosis not absolutely proven until the time of thoracotomy. So one should always carefully evaluate the conditions that might be found at the time of surgery. It is very important to mobilize the esophagus sufficiently to where the esophagogastric junction can be replaced to its normal position and fixed to the pre-aortic fascia. So we mobilize the esophagus ordinarily up to the level of the inferior pulmonary vein. You carefully evaluate the condition of the esophagogastric junction. We do open the peritoneum. We do evaluate the upper portion of the stomach. And one then may create an effective sphincter-type mechanism by several procedures. We have used a number of these. We think now the one that works best in our hands is a modification of Mr. Belz's technique. And for this, we use interrupted mattress sutures of silk that are passed through the muscularis of the esophagus and onto the gastric fundus, invaginating the lower portion of the esophagus into the upper portion of the stomach with one layer of sutures, and then using a second layer of sutures to fix the esophagogastric junction to the undersurface of the diaphragm. Now, the next step in the procedure is to reconstitute the crural sling. This is done by reapproximating the fibers of the right cruce of the diaphragm posterior to the esophagus with interrupted sutures of silk. It's important not to make this too tight. We like to have a Levine tube in place, and I like to feel that I can put the tip of my finger alongside the esophagus easily after the repair has been completed. The EG junction then is well below the diaphragm, and one has reconstituted a sphincter-like mechanism. After this has been done, I like to put an intercostal drain in and usually leave it for about 24 hours. One does not have to do this, but if you do not, you usually will have to aspirate the pleural space, and it's much easier not to have to explain to the relatives and to the patient why you're having to perform pleurocentesis so we ordinarily do put a catheter in, leave it for about 24 hours. This type of approach will work very well. Now, if the patient has suspected or known coexisting intra-abdominal disease, such as gallstones, or bleeding of unknown etiology or unknown sources, then we do feel that the intra-abdominal approach is the one that should be elected. And under these conditions, we usually like to use modifications of Dr. Hill's technique. Once again, the fibers of the right cruce of the diaphragm are approximated posterior to the esophagus with interrupted sutures of silk until one finger can be placed easily alongside the esophagus. It is important to mobilize the esophagus sufficiently to where that you have adequate length of the esophagus, and then very importantly, to be able to affix the esophagogastric junction to the pre-aortic fascia with interrupted mattress sutures of silk. We're taking figure-of-8 sutures and fixing this to the region of the pre-aortic fascia. Now, sometimes this is a rather nebulous type structure, and if it is, we like to use a median arcuate ligament or sometimes even the crural sling to be sure that we have a firm fixation of the esophagogastric junction well under the esophageal hiatus. This is a very important part of the repair. I can remember as a young man working as Dr. Harrington's first assistant, and we felt at that time that the important thing was to get a good tight closure of the crural sling. And we worked diligently at that and used fascial sutures and many other types of materials to try to carefully fix that. Now that is important, but not nearly as important as fixing the esophagogastric junction to the region of the pre-aortic fascia and reconstituting an acute angle of esophagogastric entry. After this has been done, I like to take the fundus of the stomach and approximate it to the lateral and anterior surface of the esophagus for about 4 centimeters with interrupted sutures of silk. This is a modification of a fundoplication. If the patient has had marked reflux, gastroesophageal reflux, we may prefer to use a modification of the Nissen procedure. But most of the time, the Hill procedure will work very well as a modification of a fundoplication. Now, should the patient have coexisting active duodenal ulcer disease, and the ulcer really need to have surgery because of obstruction, intractability, or continued bleeding, and I wish to do something about the ulcer at the same time, we ordinarily prefer to use bilateral vagotomy and trectomy and repair of the hernia. Should the patient have a chronic gastric ulcer, and sometimes this does coexist, and in our series of around 600 that we have done, we've had a number of these that have had firm, hard, chronic gastric ulcers. And we feel it important to be sure that this is a benign ulcer. And under these conditions, we remove the ulcer either by a wedge-type resection or a partial gastrectomy, depending upon the location of the ulcer. And of course, should carcinoma be found, then a much more definitive procedure would be done for removal of the gastric carcinoma. Occasionally, we will see reflux without the presence of an actual hernia. Most of the time, these patients that have gastroesophageal reflux do have a hiatal hernia, but it's possible to have gastroesophageal reflux without actual herniation. Under these conditions, we repair this and correct this by reapproximating the esophagogastric junction to the region of the pre-aortic fascia and doing some type of fundoplication. Most often, we felt that the Nissen type will work best in our hands, where we take the fundus of the stomach, pass it behind the esophagus, wrap it around the esophagus, and fix it in position. Now, sometimes we feel that this is a little bit more than we really need, and we actually will take the fundus and wrap it around the anterior and lateral surfaces of the esophagus, but not go completely around it. It is an effective method of preventing gastroesophageal reflux. One other little point I'd like to mention to you, and that is reflux strictures. Most of the time, patients that have strictures of the esophagus associated with gastroesophageal reflux and coexisting with hiatal hernias will receive a very good result if you mobilize the esophagus sufficiently to return the esophagogastric junction to its normal position and recreate an effective sphincter-type mechanism. Now, occasionally dilatation may be necessary. There are some patients, at least in our experience, where more definitive measures have been required. Should a very short, firm stricture be present at the esophagogastric junction that does not respond to dilatation, we have found in our experience that sometimes this stricture can be resected, and if the esophagus is of adequate length, a primary anastomosis can be performed with a very good result. If the stricture is longer, modifications of Dr. Thow's procedure is a very useful one. And in this particular operation, a longitudinal incision is made through the strictured area of the esophagus. A portion of the stricture may be removed, and then you reconstitute this by using a gastric fundal type graft. Now, if the epithelium has been completely destroyed, as it often has in the esophagus with this disease, we like to use, and Dr. Thal and Dr. Ed Woodard and many others have recommended, a split thickness skin graft applied to the fundus that you will then use for the onlay type graft. We have also preferred, as have many others, to add to this Dr. Nissen's procedure to prevent reflux. Now, we have not a large series of these, but of the ones that we have used, this is a very effective method, and it looks quite promising. For the long strictures of the esophagus that are present, better to remove these segments of the esophagus and then to use one of several procedures. One may use the one advocated by Drs. Ellis and Claggett, where they use an aclohydric segment of the stomach, an esophagogastrostomy, a Billroth 1 type of an anastomosis. Spencer Payne has recommended that you would do better to add to this the use of a short segment of jejunum between the stomach remnant and the duodenum, or a long Rouen-Y type segment to prevent reflux of pancreatic and bile fluids. Dr. Marandino in 1955 recommended the use of a jejunal graft for this. And last year at the American Surgical, he said in his 17 cases that he had followed, none of these had had complications. I would caution you that the blood supply of the jejunal graft may be precarious, and it's quite important to be very careful about the blood supply of the segment of jejunum that you might interpose. Segments of the colon are quite useful. One may use the transverse colon or either the left or right colon. Since these are usually relatively short segments, we have preferred segments of the transverse colon. It has good blood supply, it's easily adaptable, it doesn't take long to do the procedure, and in our experience has been one of the best methods of correcting a firm, long reflux stricture. We do add to this vagotomy and pyloroplasty, and the results have been quite good. And if it's a very short stricture and there is adequate length of the esophagus, one may remove the stricture and do a primary anastomosis, then fix the esophagogastric junction to its normal position, reconstitute the sphincter, and recreate the crural sling.
The second paper is Dr. Sawyer's at Vanderbilt, Nashville, How I Treat Esophageal Perforation and Mediastinitis. Dr. Sawyer.
The various causes of esophageal perforation, and as you would expect, most are due to some type of instrumentation. 7 cases were due to paraesophageal surgery. 5 of these were associated with vagotomy, and 2 occurred during repair of an esophageal hiatus hernia. Now, if one adds up these iatrogenic type cases, they constitute almost 3/4 of the total number of cases that we saw. The breakdown of the instrumental esophageal perforations, most were due to esophagoscopy, second due to esophagoscopy with dilatation of a stricture. A couple were due to gastroscopy. This nasogastric tube is rather interesting. 2 of these were due to a Saintstakon tube that was overinflated. One was due to removal of a Canner tube by the patient himself, who forcibly removed it. The site of esophageal perforations in the cervical esophagus, 7. Most occurred in the thoracic esophagus, and most of those were in the lower thoracic esophagus, not in the abdominal esophagus. The diagnosis of a thoracic perforation may be established by the clinical findings of the triad of fever, chest pain, and crepitus. Following instrumentation, the presence of chest or abdominal pain and crepitus is sufficient evidence to establish the diagnosis. Now, the signs and symptoms of cervical esophageal perforation are less fulminating than with the thoracic perforation, and these frequently include a painful, tender, swollen neck and crepitus, fever, or dysphagia. Now, of extreme help, of course, are X-ray findings. And in 20 of our 24 thoracic perforations, there was a hydropneumothorax or mediastinal emphysema as a tip-off for the diagnosis. The diagnosis can frequently be confirmed by esophagogram, preferably with gastrographin or water-soluble contrast media, and this demonstrated conclusively a perforation in 14 of 18 examinations. How about treatment and the results? Well, in the cervical esophagus, there were 7 patients who underwent treatment. In 5 of these, suture of the perforation and drainage was done within the first 18 hours following perforation, and 4 of these 5 patients made a prompt and uneventful recovery. The 5th patient had 2 perforations from a gunshot wound to the esophagus. He developed a fistula, but this closed after 8 weeks. The patient had a stricture secondary to laryngectomy and neck dissection and sustained a perforation during dilation. Antibiotic therapy was started immediately, but an abscess developed, and this was incised and drained on the 13th day. A chronic fistula resulted. He eventually recovered. The patient who died received a perforation during an esophagoscopy. He was elected by the gastroenterologist to give him antibiotic therapy. His neck became painful and swollen. He died 96 hours of laryngeal edema and extensive cellulitis without operation. We believe that all patients with perforation of the cervical esophagus should have immediate operation. If the site of the perforation can be found, and it can't always be found, it should be closed with non-absorbable suture. Drainage should always be instituted of the retroesophageal space in all patients. These are results from thoracic and abdominal esophageal perforations. There were 32 patients treated for perforation of the thoracic or abdominal esophagus. 15 of these patients had early suture, closure of the perforation, and drainage of the mediastinum, and 14 of the 15 survived. One death occurred in a patient in whom a Sain-Staken balloon tube had ruptured his esophagus, a very extensive rupture. He died a few hours of persistent shock, peritonitis, and mediastinitis. In one of these 15 patients, the suture closure of the perforation broke down, but because there was adequate drainage, the resultant fistula closed 3 weeks later. Of 15 primary closures of the thoracic esophagus, 12 were effected within less than 24 hours. Closure was also successful, though, at time intervals of 30, 48, and 72 hours. Now, suture of a surgically created perforation of the abdominal esophagus without drainage was performed in 3 patients. 2 of these made an uneventful recovery. A 3rd patient died 2 months later as a result of early suture line breakdown. He had a very prolonged course of morbidity, subphrenic abscess, peritonitis, sepsis, etc. On the basis of this, we believe that all patients should have drainage, even though their suture line appears to be adequate at the time of closure. Drainage of the mediastinum alone, without attempting repair or perforation, was done 5 times. 3 patients survived and 2 died. You can see that the mortality rate is increasing when we're not doing suture, closure, and drainage. The mortality rate increases. And then the non-operative treatment. This occurred in 9 patients. They were treated with antibiotics, nasogastric suction, intravenous fluid. In 3, healing occurred twice after esophagoscopic biopsy of a carcinoma and once after an esophagoscopy for a hiatal hernia. Now, each of these patients had chest pain and evidence of free air in the mediastinum on chest x-ray. The surgeons obviously weren't called in a consultation, but esophagograms were done and leakage could not be demonstrated. Therefore, they weren't operated on. Now, 6 other patients with this type of non-operative treatment, however, died for an overall mortality rate of 66%. Now, the results of surgical treatment relative to the time factor, when the patients are seen and treated within less than 24 hours, the results are generally good with a 13% mortality. However, the mortality rate when treatment is delayed beyond 24 hours is 3 times that when they're seen within the first 24 hours. The fact that some small perforations often can be treated successfully by conservative management, we don't question, but the difficulty occurs in classifying a perforation as small or predicting the ultimate effects of a small perforation. Early changes on chest x-ray or the size of the rent, as determined by an esophagogram, provide an unreliable index to the future course of events. Now, the most difficult type of esophageal perforation to diagnose is spontaneous perforation of the esophagus. This condition, known as Boerhaave syndrome, was first described in 1714. Vomiting after heavy food intake associated with a liberal alcohol ingestion is a classic history of spontaneous rupture of the esophagus that Boerhaave described almost 250 years ago. Now, the diagnosis of spontaneous rupture of the esophagus is frequently delayed because the patient's symptoms masquerade as acute pancreatitis, myocardial infarction, perforated duodenal ulcer, or hiatal hernia. At least these, in our experience, are the most common erroneous diagnoses associated with Borjas syndrome. Characteristic findings with spontaneous rupture of the esophagus are cyanosis, which occurred in a half of our patients, subcutaneous emphysema, which can usually be palpated first in the neck, and is considered by some thoracic surgeons to be a late sign, but we have seen this as early as 6 hours after esophageal rupture. The abdomen may be rigid and tender, and there's frequently an associated hydrothorax. The usual operative findings of a spontaneous rupture of the esophagus perforation usually occurs in a normal esophagus. It's a linear tear that is on the left side of the esophagus just above the diaphragm, and the length of the tear in our series is varied from 2 to 8 centimeters. Now, once the diagnosis is made, the treatment is immediate thoracotomy, suture of the tear in the esophagus, using non-absorbable suture material, removal of all the debris, and very wide drainage of the mediastinum and pleural cavity with large thoracostomy tubes. Temporary gastrostomy, we think, is a good thing to do. It allows earlier feeding and provides a means of maintaining nutrition should the esophageal repair fail to heal. Recently, if we have run into persistent esophageal fistulas, we've placed the patients on total parenteral alimentation and feel that this has distinct advantages.
The short bowel syndrome and post-blegotomy diarrhea by Dr. Linwood Harrington.
The first successful massive resection of small bowel performed in man was done by Coburn in 1881. Since that time, many single case reports have appeared in the surgical literature describing both early death and long-term survival following massive resections. The results have not been consistently related to the length of the small bowel remaining. There's also conflicting experimental studies in the literature as to whether the remaining jejunum adapts better than the ileum following massive small bowel resection. Everyone is in agreement, however, that to retain the ileocecal valve is of utmost importance in delaying transit. Also, the development of gastric hypersecretion is inconsistent and unpredictable following massive resection. It has been shown experimentally, however, that antral resection would largely prevent gastric hypersecretion following massive resections. The work of John Hammer has shown delayed transit following the reversal of a small segment of bowel after massive resection. No one surgeon, however, has had more than an occasional experience with the problem of reversing a short intestinal segment following a massive resection. Only 22 such reversals have been reported in the American literature, and all were reported before the use of total parenteral hyperalimentation. I think that this certainly has changed the problem, and I think that many of these patients with the short bowel syndrome can be tided over, and then they adapt. And I think with TPA, many of them probably will not have to be operated upon. As you know, the indications for massive small bowel resection are extensive trauma to the small bowel, volvulus with gangrene, the radiation effect, inflammatory disease, or mostly we encounter, of course, regional ileitis, enteritis, extensive mesenteric thrombosis. The operations that have been used to delay transit have been the use of a single reverse segment, about 10 to 12 centimeters in length, or even shorter, paired or double or reverse segments, one placed high in the remaining bowel, one placed low, a circular recirculating loop, a reverse circular loop, a circular loop with an anti-peristaltic segment. Vagotomy, as you know, will delay transit. Stripping of the longitudinal musculature of a small segment of the remaining bowel is practiced by Marion Anderson of Toledo, and also Bill Wardell, as you know, has attempted to construct a valve-like mechanism in the remaining bowel. But for the most part, this work has been experimental because the operation is not without some complications. Obstruction can occur, as well as gastric stasis, gastric ulcer, massive hemorrhage, and whatnot. And as I stated, no one individual has had nothing but a limited experience with this problem. I think that if I encountered the small bowel syndrome, if TPA does not tide the patient over, the patient does not compensate in the follow-up period, I would be inclined to reverse a short centimeter segment of jejunum. I think if 2 or 3 feet of small bowel was present, I would reverse about an 8 to 10 centimeter segment. If only about 8 to 10 inches was left, I would reverse, of course, a very short segment, about 3 to 4 centimeters. And if the ileocecal valve has been sacrificed, then I would just create one right above where I anastomose the remaining bowel into the colon. The point is, when I operated upon the patient and took out a large amount of the small intestine, did a massive resection, at that sitting, I would not put in a reverse segment. I would elect to put the patient on TPA, watch the patient carefully. Subsequently, if the patient was uncontrollable, then I would put in an antiperistaltic segment. And I would do the simplest, a single reverse segment, not a circular loop or any of the other fancy loops which are purely experimental. Now I'd like to say just a little bit about post-vagotomy diarrhea. For post-vagotomy diarrhea that's uncontrollable, we take a 10 to 15 centimeter segment of jejunum, 100 centimeters beyond Treitz ligament, reverse it and reanastomose it in continuity. Dr. Sawyers and I, over the past 5 years, have operated upon 9 of these patients. The oldest patient is 5 years, and I believe the youngest follow-up is 2 years. These patients had from 10 to 25 stools per day. They lost 20 to 80 pounds in weight. They were anemic. The transit time for mouth anus was 5 to 15 minutes. Each has been markedly improved. They now have from 1 to 3 stools a day. One of them gained a small amount of weight. One gained back to the ideal weight. 4 are below the ideal weight. The transit time is 1 to 6.5 hours in 8 patients. It's 30 minutes in 1 patient, but this one patient has been markedly improved. And Dr. Edgar Poth, instead of reversing the bowel counterclockwise and twisting it on his pedicle, prefers to do it in another manner. He takes a 20 centimeter segment of bowel and divides it. He then takes the bowel proximal to the area that he's going to reverse and anastomoses it to the distal end of the bowel. He then takes the distal end of the bowel beyond the 20 centimeter segment and brings it up proximally, so that he ends up with not a mechanical reversal, but a physiologic, an anatomic reversal. In other words, he does not like to distort the vascular pedicle, and he feels that this is a much better way of doing it. However, it is much more time-consuming. On the other hand, the Russian surgeons have a very ingenious way of doing this. They take a loop of bowel that they wish to use for the antiperistaltic segment, and they measure it 15 to 20 centimeters and divide it. They then take the bowel above the isolated pedicle and take the proximal end of the intestine and anastomose it to the distal end of the reversal. They then take the proximal end of the reversal and anastomose it to the bowel below the reversal. So in essence, they have an antiperistaltic segment with no twist of the mesentery, and it's quite easy to do. Now, during the past several years, Dr. Sawyers and I have also operated upon 3 patients who had disabling vasomotor and gastrointestinal symptoms of the dumping syndrome and also disabling post-vagotomy diarrhea. We treated these patients with a double reversal, one placed between the stomach pouch and duodenum to correct the vasomotor symptoms of the dumping syndrome, and one placed at the 100 centimeter level below Treitz ligament to correct the post-vagotomy diarrhea. And when we put in the double reversal, we prefer to put in the distal reversal of the reversal at 100 centimeters first. We measure the bowel. We then place non-crushing clamps on it and isolate the pedicle. We then rotate it counterclockwise 180 degrees and reanastomose it in continuity with a 2-layer suture material in the reverse segment. Now we direct our attention to taking down the gastric resection to put in the proximal reversal. We then divide right through the gastroduodenostomy, remove the suture lines, and freshen up the duodenum and freshen up the stomach. We then go down about 24 inches below Treitz ligament and pick up a segment of jejunum and bring it right to left, or antiperistaltic, about 10 centimeters or 12 centimeters in length, and interpolate it between the stomach and the duodenum. Now, this segment should not exceed over 10 to 12 centimeters, preferably about 10, whereas the one at 100 centimeters, you can make it up to 15 or 18 or so. We put in this reverse segment the same way. We put on the non-crushing clamps, isolate it, and then anastomose it to the stomach and to the duodenum in an antiperistaltic fashion. It being divided and being interpolated between the two. And after we do the anastomosis, then we take the afferent limb of jejunum proximal to the pouch, the efferent limb of jejunum, bring it through the transverse mesocolon, and restore continuity with an end-to-end jejunal jejunostomy.
The conclusion of our third How I Do It presentation also signals the end of Side A of your program, Doctor. Side B can be heard by just flipping over the cassette or 2 reels on your tape recorder. Continuing a program of 6 How I Do It presentations recorded at the American College of Surgeons sectional meeting in New Orleans, this is Side B, Audio Digest Surgery, Volume 18, Number 10. And here again is Dr. William H. Moritz to introduce our fourth expert.
How I treat cardiac arrest by the originator of the procedure that saved many, many lives, Dr. James Jude from Miami.
Cardiac arrest certainly remains with us in the operating room. The problem of treatment of sudden death or cardiopulmonary arrest, and I'd like to emphasize cardiopulmonary arrest because both must be treated, both the circulatory arrest and the cardiac arrest, is certainly a true problem. Cardiac arrest during surgery still occurs in between 1 and 1,200 and 2,000 general anesthetics. Almost every surgeon is sometime or other going to run into this problem, and those that carry out emergency surgery are going to run into it more often. The etiology of cardiac arrest is manifold in surgery. Most commonly, it is due to asphyxia, idiosyncrasy to anesthesia, or to a vagal-vagal type of reaction. Blood loss also can be incriminated in traumatic type of cases, or lack of replacement of adequate fluid volume. I'd like to emphasize that the best treatment of cardiopulmonary arrest is prevention. Obviously, if you can prevent the problem, you don't have it. Next one has to consider recognizing the problem. I'm going to speak of it in the general context of occurring either immediately pre-op, intra-op, or immediately post-op in the recovery room. You should be able to recognize the problem immediately. Now, that's between you and the anesthesiologist. The two of you together should be able to recognize that sudden circulatory collapse has occurred. The anesthesiologist can recognize this problem by keeping good tabs on the pulse and on the electrocardiogram. Now, electrocardiograms aren't routinely taken on all patients undergoing surgery, but it's becoming more and more common. I'll tell you right now, if you have a cardiac arrest and it ends up in a court of law, as it could perhaps, the first thing they'll ask you is, was the electrocardiogram monitored? You can't monitor this on all patients. It becomes impractical. But if it's an elderly patient, it's a patient with heart disease of any type, or it's a patient with pulmonary disease, then the electrocardiogram should be monitored, and it's easy to do that today, and the anesthesiologist can do it with a cardioscope during the procedure. The surgeon should certainly be ready to recognize immediately the absence of any capillary bleeding. If you're suspicious of the possibility, check with the anesthesiologist and immediately palpate for a major pulse, such as a femoral. If you're in the abdomen, palpate the abdominal aortic pulse. Both of you together should be able to recognize immediately the problem. It's procrastination, it's delay in recognition that has a poor outcome. Now, what are you going to do in the treatment of it when you recognize it? One, the time factor is of the greatest importance. If you start resuscitation procedures immediately, in almost all cases in the operating theater or immediately pre-op or immediately post-op, you should be able to get the heart restarted. And most times you can. Next question is, can you keep the brain alive? You haven't truly resuscitated the patient unless you can keep the brain alive also. You have to get them back to the same state they were before you were putting them to sleep to do the operative procedure. So the time factor becomes important, and that has to do directly with your recognition. Within about 3 minutes or 5 minutes, nobody knows exactly, and it depends on the age of the patient, cerebral circulation, and multiple factors, the brain will die irreversibly if there is no circulation. So the quicker you get circulation reestablished, even artificially by cardiac compression and by use of ventilation, the longer period of time you have to get them resuscitated, and of course the better the results will be. And then you must reestablish the oxygenation system. The anesthesiologist should immediately ventilate the patient with 100% oxygen, and you start external cardiac compression. In the operating room, this can be begun through the drapes that are on the patient. You're doing an abdominal procedure, you can immediately begin external cardiac compression through the drapes, or if you're so inclined, You can make an incision in the diaphragm, and you can do direct cardiac compression through the diaphragm. Whatever you do, don't procrastinate, because that's where the problems occur. It's not the technique that's used. You can open the chest too if you want to, take the drapes off and make an incision in the chest and do direct cardiac compression. It makes no difference, but don't procrastinate. Finally, in regards to specific therapy, drugs and defibrillation are of greatest importance to reestablish circulation immediately. Now, probably one of the most important points in resuscitation is the use of pharmacological agents. And should they be used? Unequivocally, they should be used in every case of cardiac arrest, even though the heart comes back almost instantaneously. At least a cardiotonic vasopressor agent, an ionotropic agent, such as adrenaline, should be employed. Also for the aid of defibrillation, to improve blood pressure after resuscitation, reverse acidosis, and to sustain blood pressure if it doesn't remain up after the resuscitation. Technique of injecting the drugs: if you've got an IV going, you don't have to do this. If there's no intravenous in the patient, then you should use direct intracardiac injections using a number 22 3½ needle. You can use either this approach, or you can use a subxiphoid approach or a parasternal approach to inject the drug into the blood inside the heart. Inject the drug with the chest open with direct cardiac compression. Now, the drugs to be employed, to just go through these very quickly, initially give a ½ milligram of adrenaline, dilute it out 1 to 10,000, and then give 5 cc's. That will give you a ½ milligram. This should be repeated every 5 minutes. Sodium bicarbonate, 44 milliequivalents, and that's been arbitrarily selected only because it generally comes in ampules of that amount, and it's worked out extremely well. Should be given every 5 to 10 minutes. Take arterial PO2 if you can, PO2 and pH and the base deficit. In this manner, you can determine exactly what you need. But if you can't get this, and many times you can't, then give every 5 to 10 minutes, 5 to 8 minutes, let us say, 1 ampule of sodium bicarbonate. If you get an electrical activity of the heart, or weak contractions but no good pulse, then give a ½ gram of calcium chloride or calcium gluconate intravenously every 5 minutes. This strengthens myocardial contraction, counteracts the hyperkalemia, high potassium in the coronary blood. And this will be a good ionotropic agent and improve the myocardial contraction. If you have an irritable myocardium that goes into ventricular fibrillation, then you would use lidocaine in 25 to 50 milligram aliquots and defibrillating the heart in between with continued cardiac compression and artificial ventilation, of course, until the heart will defibrillate. You must determine what type of cardiac arrest the patient is in. You do this by either a cardioscope, and you have the patient is either in asystole, ventricular fibrillation, or what we call profound cardiovascular collapse. The asystole is straight line. Ventricular fibrillation is the erratic twitching activity. Profound cardiovascular collapse is an irregular, depressed AV node. It's a poor electrical activity, but without any cardiac output. The heart has electrical activity, but if you looked at it, it isn't contracting or feebly contracting. So you have to determine what type of arrest you have. The chest is open. It's easy to do because you can look at the heart. The chest is closed. You're using external cardiopulmonary resuscitation. You have to take an electrocardiogram. There have been a number of failures of resuscitation because people have stopped resuscitation without ever taking an electrocardiogram, and the heart may be in ventricular fibrillation. And if it's in ventricular fibrillation, one has to defibrillate the heart. Today, the direct current defibrillators are the best. There still may be a few alternating current defibrillators around. They're perfectly okay, giving 440 volts alternating current, but generally 200 to 400 watt seconds, or joules, in the direct current defibrillators are the best. Nobody should be touching the patient, and you should have a defibrillator with the shock under your control. If you ever have gotten a shock, you'll know why. I have. And after you've resuscitated the patient, hopefully, then you want to give them post-resuscitation care to decrease any cerebral edema. If the patient awakens right away, fine. Everything went well, he's awake, he has no brain damage. But if he doesn't awaken, you can give him 40 grams of urea, which could cause him to void in large quantities to decrease cerebral spinal fluid pressure. You can give him hypothermia to 30 to 32 degrees centigrade for 72 to 96 hours, which will further decrease cerebral spinal fluid pressure. You can also use corticoids to also have the same effect. And finally, in cardiac resuscitation, too often it's said, too little, too late. and that is frequently what the problem is in cardiac resuscitation. You have to be ready immediately to provide effective therapy.
With almost 2,000 Americans dying every day from its effects, coronary artery disease is of enormous clinical and almost epidemiological importance. Let's listen now as W. Dudley Johnson tells us how he treats this devastating disease.
Surgeons for years have tried to revascularize the heart with a variety of techniques, most of which were not very successful or not at all successful. With the advent of the vein graft 3 to 4 years ago, the technique has enormously expanded and has become very popular. Most patients get double grafts, and in our experience for the last 2.5 years have had double or triple or more bypass grafts inserted, since isolated single artery coronary disease is relatively infrequent. Perhaps the thing which made this surgery most possible was recognition that a coronary heart can tolerate intermittent anoxic arrest, and the field and the suturing can therefore be done in a perfectly dry, quiet atmosphere. This really then sort of extends it so that many of the principles of surgery are the same of what has been used in other areas of peripheral vascular surgery for many years. But indeed, the heart does tolerate anoxic arrest very well, and this has allowed vein grafts to be inserted into all areas of the heart. Many clinics still are rather selective in their patients and accept patients only that have good visualized distal vessels or reasonably good ventricular function. Early in our experience, we accepted nearly all. We have become a little more selective in the last year or so. Nevertheless, we still continue to accept a great preponderance of patients with significant disease. In our first 6 months last year, 218 patients were found in our catheterization laboratory to have moderate to severe coronary disease. And out of that group of 218 patients, 88% were referred for surgery. We have consistently been accepting somewhere in the 90% category of patients for surgery that have had demonstrated significant coronary disease. Last year, out of 480 some patients operated during the year, our mortality was 10%. This is higher than in several reports that you will see, but many of these reports completely fail to specify the percentage of patients they accept or identify the percentage that are refused surgery. And this, of course, makes evaluation of mortality statistics difficult. Mortality rates in this surgery, as with any other surgery, clearly relate to the patients which are accepted for the operation. Not only can you bypass blocked areas, but the vein is several times bigger than a coronary, can function as a patch graft. This bypass and patch graft combination has been useful in at least half of the patients in whom we operate in at least one of the coronary vessels. Absence of visualization of a coronary artery distally has sometimes been used as a reason not to operate. We think it is grossly wrong to refuse surgery to patients simply because you don't see a distal artery on the cine study. While cine studies are absolutely essential in the approach to this disease, they do have limitations. They don't show you arteries that are totally blocked and don't fill distally, nor do they show you what's in the wall of an artery. All they tell you what's in the lumen. In the most right coronaries, or at least in 2/3 of patients with a total right block and a non-visualized distal right, an adequate artery can be found into which to place a bypass. This occurs less frequently on the anterior descending and still less frequently in our experience in the circumflex. Nevertheless, non-visualized artery is not at all unusual to find a perfectly adequate vessel at the time of surgery. The left main stenosis, in our experience, is the most favorable for surgery, in contrast to the left main occlusion, in which 100% have expired. Total occlusion of the left main is a very critical lesion. Few do survive it, and in the few we've operated on who did survive, it had such extensive myocardial fibrosis and damage, they did not survive surgery, and this is one group that we are extremely reluctant to operate on, since we've lost 5 out of 5 at surgery. On the other hand, the left main stenosis still has a good myocardium, and we have not lost a patient in that category, and I believe now have 25 to 30 in whom we have operated on. A single vein perfuses a huge area of the coronary system, and these patients do extremely well. But again, the isolated single block in a big dominant vessel is an infrequent occurrence. Left ventricular failure has been indication for refusal for surgery for years in many groups, and many groups still are reluctant to accept these. This does not necessarily indicate that surgery should not be done, although we now do refuse occasional patients because of too severe left ventricular failure. However, it has to be extremely bad. Any other condition that's present should be corrected. If they have associated valve disease, it should be corrected with a double bypass, plus the valve replacement at the same time. When it comes to other associated diseases, particularly atherosclerotic in nature, they are commonly seen in this group of patients. We are reluctant to do coronary surgery on a patient with a tight carotid stenosis and really don't know anybody that will put this kind of patient on bypass. Earlier in our experience, we corrected preliminary carotid endarterectomy before coronary surgery. The patient had an infarct and died 2 days later. During the past 15 months, if there is associated carotid and coronary disease, both are corrected simultaneously. The carotid is done initially, followed immediately by the coronary surgery, and we've had uniformly favorable results with this combined approach. Patients with aortic disease, our vascular surgeons now almost routinely send these patients through to have their coronaries fixed before their aneurysms or the wrist problems are corrected. The situation can work in reverse, however. All of you who have done many aortics have certainly had a patient occasionally with an acute infarct following the aortic surgery. I should say a word about the Weinberg procedure. I think it's unfortunate that virtually all centers in the country have abandoned this. We have not. I know Dr. Favalaro and Cleveland Group has not. We do have increasing evidence of function. On last week alone on a repeat operation, the patient, we measured 60 to 65 cc flow through his mammary implants from 3 years ago. He had developed progressive disease in the right coronary, and we went back and inserted a right vein graft. This and other studies increasingly have convinced us that these things can supply blood to the myocardium. They're not comparable to a vein graft. However, if an implant works, it gets better year by year, and the same cannot be said about vein bypass grafts. We use a variation of the technique where the main artery is dissected and the intercostal branches are all dissected free and left attached to the main artery. As this is placed over the surface of the heart, side branches are individually implanted. Beneath multiple separate segments of the coronary system, we will average 5 or 6 implants per patient. We do feel that this has many distinct advantages over the usual single tunnel technique. We do combine this now in perhaps 25 or 30% of patients with vein grafts. There are patients with diffuse coronary disease that you can only get one vein graft in with, say, 2 or 3 vessel disease, and we would think these ought to be combined with implants. But you cannot bring separate blood into 4 or 5 different smaller areas of the coronary system with a conventional Weinberg, nor can you with a vein graft. With these multiple implant techniques, this can be achieved on occasion. Not everything about this surgery is beautiful. There are problems. Surgery is not now, nor will it ever be, the ultimate answer to coronary disease. Here are some of the patients that we studied both early and late. So far we have 67 in our initial study who have had repeat catheter studies 1 or more years later. In this initial group, 96 veins were placed, 86 were open, or 89% were open on the first catheterization study. A year later, we've had an additional failure rate of 12%, so that 74 veins are now open. 77% of those put in initially were open. If the veins were open 2 weeks after surgery, there's an 86% chance they'll be open a year later. If anything, these statistics are weighted on the unfavorable side because anybody with recurrent symptoms has been brought back in and recatheterized. We're in the process of bringing back another 100 patients who had early studies, and we'll want to see how the veins look later on. At the present time, a number of things that you can expect as far as coronary surgery is concerned. We consider at least 90% of patients operable. In our experience last year, 3 out of 480 some, or less than 1% of patients had such diffuse disease that no bypass could be inserted. 70% of the patients have received from 2 to 5 grafts. Relief of angina is close to 100% in these patients. 5 to 10% may have some residual angina if you get only 1 graft in with diffuse disease, but there's marked relief in nearly all. Relief of failure symptoms is often present, and sometimes it's very dramatic, but it is less predictable than the relief of angina. We cannot differentiate ischemic but viable myocardium from fibrosis and scar. The operative mortality in most centers now, which are accepting a huge percentage of patients, is in the 5 to 10% category. We do not like to operate on patients with diffuse ventricular dilatation without angina. Angina tells us you've got ischemic and viable muscle. You do not get angina from scar and fibrosis, especially if they used to have angina. After a series of infarcts, it's all gone. We're reluctant to operate. We have no age limit. The oldest has been 79 with a successful double graft, but if there's gross ventricular failure, we're reluctant to take them over 70. Secondary organ deterioration severe, of course, contraindicate surgery. We don't know the long-term results yet, beyond what I've already described. Nevertheless, I think they are encouraging at our present stage of the game. There's no answer to surgery for the acute infarct. I find it most distressing to see medical people now talking about the salvation is to whip in a pump, put them on the balloon assist, take them to surgery and angiograms and acute infarct and put in a vein graft. The same medical people have often refused to send them for angiograms for 6 months or a year or 2 or 3 with progressive symptoms prior to their devastating infarct. To think that this type of mechanical assist is going to be the salvation of these patients, I think, is grossly erroneous. To me, this is comparable to waiting for carcinoma of the colon patients until they're obstructed. I think there ought to be much more effort on identifying the patients earlier and doing the surgery before their devastating infarct. However, we still cannot at this stage define accurately how soon nor how late this surgery will be applicable. Surgery, besides relieving angina, all of our studies do indicate that it unquestionably also improves ventricular function, but this improvement has been much better if the surgery is done earlier in the course of the disease.
Taking over the microphone now, our final discussant, Hermes C. Grillo of Harvard Medical School, to discuss how I treat tracheal stenosis.
I'm going to deal entirely with the subject of stenosis which follows intubations of various types. I'm going to ignore the stenoses which follow infection. They're extremely rare. Tuberculosis and diphtheria aren't seen very much now, at least as causes of stenosis. And the other cause which we see increasingly frequently, but not anywhere nearly as frequently as this, and that is post-traumatic, principally steering wheel injury type problems, which are quite complicated in their own right. The post-intubation stenoses obviously are iatrogenic in origin. We see more and more of them as more and more ventilatory therapy is given through cuff tubes. On the other hand, it's important to remember that a fair number of these stenoses occur simply by virtue of using a cuffed tube without any ventilator attached to it. We've seen this with patients who've had a cuff tube in place after a radical head and neck surgery simply to prevent aspiration in the early days. It's important also to keep in mind that the stenoses, by and large, occur in 2 locations. There are a whole complex of possibilities, but these are the 2 stenotic lesions, my subject for the day, the first being at the tracheal stomal site and the other at the cuff site. Now, at the stomal site, the problem is largely one of cicatricial healing of a defect which has been made by the surgeon and compounded by the aftercare. In other words, if the hole is made too large, if the heavy prying equipment is used, which erodes a further hole, and if there's a considerable amount of sepsis, then a huge defect is created, and in the healing you can get stricturing. Most of it is clinically unimportant, but in a fair number it can lead to fairly complete and sometimes fatal occlusion. The stenoses, therefore, are anterior and lateral in that region. The back wall is rarely injured. On the other hand, at the cuff level, where the erosion of the cuff tube is circumferential, one gets a circumferential stricture in the healing process. Again, the result of the healing of direct tracheal injury. The patients, of course, present with the signs and symptoms of upper airway obstruction, namely dyspnea, and then they rapidly present a little stridor, and some of them will have respiratory obstructive episodes, which may be relieved by suctioning or coughing, or they may die in the first episode. A few of them will present with pneumonia. And I think if there's one message which I have to give today, it is that any patient who has had an endotracheal tube in, or even worse still, a tracheostomy, in the previous 2 years to the time when he is seen with signs of upper airway obstruction, has got an organic obstruction until proved otherwise. I haven't counted them, but of the 50-some-odd patients we've seen with this disease, my guess would be that 15 or 20 of them had been treated for asthma, so-called asthma in quotation marks, prior to their disease being recognized. And I know there are patients who die of this who have been treated with steroids right up to the limit. I have one in the hospital now who went unconscious before the lesion was recognized while being watched in a hospital and being treated with increasing doses of steroids. The second, I think, important thing is that once these patients begin to develop symptoms, they're awfully close to obstruction. We have found that with patients who are still sedentary from the disease that originally required their respiratory therapy, that these people will get down to approximately a 5-millimeter airway before they begin to have symptoms.
One of the people in our medical pulmonary unit has done some experiments with volunteers and also measured patients and finds that, again, at rest, until the airway gets down to the critical diameter of about 5 to 6 millimeters, that you really don't have symptoms at rest. This is sort of startling, but it's a fact. And most of the ones we've seen clinically have had the same cutoff point at the time when they became totally obstructed or became suddenly very, very obvious to us. The diagnosis, once you suspect it, is pretty simple, and that is to get some x-rays, and we don't do anything very elaborate. We'll simply do laminograms. A simple oblique view with fair amount of penetration will show the air column of the trachea turned away from the clavicles, which often obscure to the point of stenosis, and you can see the column come down and see the narrowing and then follow it on down into the chest. We've avoided contrast because the liquid contrast media can easily precipitate an obstructive episode in one of these patients. The group in California are using powdered tantalum, have had excellent results with it, and we've begun to use this, but we haven't used it enough for me to say very much about it, except I like the idea. So in addition to the oblique views and the laminograms and fluoroscopy to show the presence of malacia, which I won't go into today, but is an important part of the correction process, we do lateral neck films. It's important to differentiate these, and I just mentioned this now for differential diagnosis, because there are a lot of obstructive lesions following tubes. I won't even mention the ones at the laryngeal level. We are familiar with those from endotracheal tubes. But going on down at the stomal site, we not only have the stomal stenosis in front, but there are also granulomas which occur with or without a stenosis. And of course, those can be treated quite differently endoscopically. At the cuff level, one sees the circumferential stenosis, and down at where the tip of the tube may pry, you could get an erosion with granuloma formation, and we've seen this in a number of children who are young enough to be ventilated without a cuff following cardiac surgery, and then will develop an erosion at that point. And between the area, between the stoma and the stenosis, one sees varying degrees of malacia, which we initially didn't appreciate enough, and in fact, at least one of our surgical failures was the result to appreciate that, and of course now we would resect that along with it or else otherwise splint it in various ways. Going on now to the problem of treatment, there's really no trachea left in many of these patients, and this is why the conservative treatment has been largely a failure in the management of these cases. Some of the incomplete strictures and some of those that are mild can be handled by repeated dilatations of stenting. Even if they're splinted for 5 years, you can pull the tube out and they'll often be obstructed within 40 minutes. We've had this experience on numerous occasions. So that we feel that these should be treated surgically if the patient is otherwise a candidate for surgery. And obviously, one can manage most of these patients with dilatation and the replacement of a tracheostomy tube, unless the stenosis is immediately above the carina. So that there are alternative methods of treatment. But on the whole, we feel that surgical treatment is the treatment of choice. The approach is now, the majority through the neck alone, dissecting back into the mediastinum along the trachea. If we need a little more working space to get down in there simply to do the job, we split the sternum partway down. There's no point in going all the way because the trachea is by that time back on the vertebral column and great vessels are in the way anyway. The exposure is something like this, just depressing the innominate vein and getting the innominate artery out of the way, and then dissecting close onto the trachea so that we never visualize the recurrent nerves. I'm sure that would be the quickest way in this disease to get recurrent nerve injury, and that would be to see them. It's quite different from our approach to tracheal tumors. There, of course, we skeletonize the nerves and so on in terms of node dissections. The whole trachea is exposed from the cricoid, usually to the bifurcation anteriorly. We don't go circumferentially because the blood supply is lost. These are all technical points. Having gotten in there, we, as quickly as possible, get a control below the level of the obstruction because they can get worse while you're working. It would be possible to dilate them, but it's rarely necessary. And then simply intubate across the operative field and then peel this thing off either the vertebral fascia or the esophagus, where it is usually densely attached. Then the completed anastomosis is simply a single layer of sutures. Through the chest, the approach we more often use for tumors, if we're down near the carina, and some of these, if people do tracheostomies by the old textbook method of extending the neck and making a cut above the suprasternal notch, they end up with a low tracheostomy and an even lower stenosis. So we've seen a few down there. And these we simply handle by running a tube through the left main bronchus And if the PO2s begin to drop, then we clamp the pulmonary artery. Otherwise, we don't, depending on the status of the patient's lung. And simply do it in much the same way, again using cervical flexion as the principal means in this disease of getting extension or length on the trachea.
We'll cease at this point with our sincere thanks to the members of the panel who've given outstanding service.
And may we add our thanks to the participants and to the Board of Regents of the American College of Surgeons for their cooperation in recording and disseminating this material. Audio Digest Surgery is produced and copyrighted twice each month by the Audio Digest Foundation, a nonprofit subsidiary of the California Medical Association.